Good afternoon, everyone. My name is Jázmin Németh, and my PhD thesis title is Oncocardiology. I'm a medical student at Semmelweis University. I'm at my 5th year, and I'm also an MD PhD student at the Institute of Pancreatic Diseases. Here you can see the members of my team. Our vision is that the prognosis of patients with pancreatic cancer can be improved by addressing non-cancer related morbidity. And we would like to achieve this by providing further evidence-based recommendations on the management of cardiovascular comorbidities, which can help improve patients' prognosis. To achieve our aim, we have two specific goals. The first one is investigating the prevalence of cardiovascular morbidity in pancreatic cancer patients, and the second one is investigating the prevalence and risk factors of cardiac cachexia in cancer patients. Both will be a systematic review and a meta-analysis, and the first topic started in September, and the second one started in October. Moving forward to my first topic. Why is this topic important? Pancreatic cancer has a high mortality rate. To give an exact number, there were around 500,000 new cases of pancreatic cancer in 2020 worldwide. Growing evidence suggests that patients with cancer, specifically with pancreatic cancer, has a higher chance to develop cardiovascular comorbidities. Also, studies suggest that cardiovascular comorbidities or diseases and cancer are not separate entities, but they are connected through common risk factors, pathological ways, and genetic predisposition also. Based on this information, it's clear that there's a need for preventive interventions to mitigate this risk and improve outcomes for pancreatic cancer patients. Our specific clinical question is, what is the prevalence of cardiovascular comorbidities among patients with pancreatic cancer? To investigate this question, we would like to use a COCO-POP framework, where the condition is cardiovascular comorbidities, the context is pancreatic cancer, and the population will be adults. The clinical implication of this topic is that if we can identify and address cardiovascular comorbidities early, that will improve prognosis of pancreatic cancer. Here you can see our final search key, which is a little bit huge. It has two domains. The first domain is about the pancreatic cancer, and the second domain contains all the relevant and the most common cardiovascular diseases and symptoms. Also, you can see the three databases where we did the investigation. At the starting point, we had 40,000 articles. After the duplicate removal, we got almost 29,000 articles, and now we are at the stage of the title and abstract selection. Here you can see the exact strategy of our title and abstract selection, and I need to highlight that even though we have a huge number of articles, we are done with the half of it. Moving forward to our second topic, investigating the prevalence and risk factors of cardiac cachexia in cancer patients. That is well known, cancer is a leading cause of death worldwide, nearly 10 million deaths per year. But what is rarely known, that almost 80% of the cancer patients suffer from a metabolic syndrome, wasting syndrome, known as cancer-induced cardiac cachexia. I need to highlight the word cancer-induced because there are other diseases, for example, chronic inflammatory diseases like COPD, where we can see this wasting syndrome, but we are only interested in the cancer-induced form. This syndrome is characterized by low left ventricle mass, which is associated with poor cardiac function, and that leads to an increased all-cause mortality in cancer. For the investigation, we have two clinical questions. The first question is, what is the prevalence of cardiac cachexia? And the second one is, what are the risk factors for cardiac cachexia in cancer patients? We have two different frameworks for the two different questions. The first is a COCOPOP for the prevalence, and the second one is the PFO, where the population is cancer patients. The factors will be any reported clinical biological factors that we would find, and the outcome is cardiac cachexia. Also, we have two different hypotheses. The first is the prevalence of cardiac cachexia is increased among patients suffering from an active cancer. And our second hypothesis is that there are specific risk factors that predispose cancer patients to developing cardiac cachexia. The clinical implication of this topic is that by addressing and treating complications of cancer, such as malnutrition and decreased cardiac function, we could improve patients' prognosis and maybe their survival. Here at the summary slide, I would like to mention that the planned submission date of the first topic is 2024 June, and for the second one is 2024 December. I would like to end my presentation with a quote by Oscar Wilde: "Success is a science. If you have the conditions, you get the result." Thank you for your kind attention.
Thank you very much for this nice presentation. Do we have questions?
Nice presentation. For the second topic, I'm just curious, cancer patients, so the whole population, cancer, all patients with cancer, or you want to just solid tumors or hematologic malignancies, or all the patients who has diagnosed with any kind of cancer?
At this point, we involve all the types of the cancer because we don't know if which kind of data is out there in the articles. And after the data extraction or the full text selection, we can maybe make subgroups based on the different types of the cancers. Thank you.
Congrats, very nice talk. Could you maybe explain us how do we make the diagnosis of cardiac cachexia? This is a bit a new topic. Is there consistency among the articles regarding this diagnosis? You could tell us how, just to learn a bit about it from you.
They use different tools to measure this syndrome, but the most common is echocardiography to measure the wall thickness or the real pump function of the heart. So they give the definition based on these criteria. Thank you.
Cachexia is a general term, and but with respect to life expectancy or morbidity and mortality, sarcopenia is a lot more important. Do you plan to differentiate these subgroup of patients, or how do you plan to assess sarcopenia in these patients?
The articles that I saw already, we can show that sarcopenia and this cardiac cachexia is not always by hand to hand. So they are existing separately from each other. But cachexia is a risk factor to develop cardiac cachexia. So we would like to, yes, make more investigation on this topic to understand more deeply. Thank you.